Okay. Because when I will turn on, the broadcast, then people will see your first slide.
Okay.
Maybe.
Francesco, I think by accident, she already started the broadcast.
Oh.
Is your broadcast, then put on your first slide.
Yes, then we should just start now, I think.
Let's wait another 3 or 4 minutes for, I think if you just put your first slide on.
Oops.
Yes,
like
go
okay.
full speed. That's perfect. So maybe we should just wait and give people, there are 11 people connected right now. So
okay.
Maybe we should just wait a second so that everybody can then connect. So people are coming in. Are you on, Emmanuelle?
Yes. Yes.
Okay. Yes. I'm sorry. I just lost your slides. Okay. No. I'm fine. Okay. So people are coming in. That's usual. They usually connect to the last minute. So
yeah.
It's still not 4 o'clock. So we'll wait a couple of more minutes and then we'll start. Yeah. So Tanya, you have, I don't need to start the broadcast then, right?
Right, because I think she just clicked by accident on start broadcast and it's already started the recording. But anyway, we'll start in 1 minute, so.
So I don't need to do it. That's
No,
most
no, it's okay.
So maybe we should start then. Are you ready?
Yeah.
Okay. So good afternoon, everybody, and welcome to this ERKNet webinar. My name is Francesco Emma, and I'm speaking from my office in Rome. Before starting, let me remind you, as usual, that your microphones are turned off. But during and after the webinar, you can send in your questions through the application that is present on your screen, and I will ask your question at the end of the presentation. The webinar will last approximately 30 minutes. We will then have 15 minutes available for questions. Our speaker today is Professor Emmanuelle Plaisier from Paris. Emmanuelle Plaisier is the head of the outpatient clinic at the Department of Nephrology at Tenon's Hospital and Sorbonne University in Paris. Her clinical expertise is centered on the care of adult patients with hereditary kidney diseases, idiopathic nephrotic syndrome, and immune-mediated glomerulonephritis. She's also actively involved in transition clinics in collaboration with the pediatric nephrology departments at Robert Debré and Trousseau Hospital, and is actively involved in 2 French national reference centers for rare disease, namely idiopathic nephrotic syndrome and inherited kidney disease of children and adults. Emmanuelle Plaisier is also a local coordinator for ERKNet. She first described the HANAC syndrome related to COL4A1 mutation in 2007, and since then she has developed a translational research program to better understand this disease. Emmanuelle, please.
Thank you, Francesco. Hello, everybody, and welcome to the webinar. Today, my job is to give you all the information to detect potential patients with COL4A1-related disease who have a specific renal manifestation. Oops. The next slide don't come. Oops. There is a problem with the next slide. I can't go.
You should just go ahead in your computer as you usually do. We are seeing your computer. That's what we see.
Yes.
So it's your computer that is actually
blocked. Oof. Yeah, sorry.
We'll give you an extra minute, don't worry.
Yes. So a brief introduction of collagen IV. It is a network forming collagen, and it is the main basement membrane component. There are 6 isoforms, namely alpha-1 to alpha-6 collagen IV chains, and they assemble in 3 heterotrimers to form collagen IV molecules. The first heterotrimer is composed by 2 alpha-1 chains and 1 alpha-2 chains. The second heterotrimer, you well know, is composed by 1 alpha-3 chain, alpha-4 chains, and alpha-5 chains. And the third collagen IV molecule is composed by 2 alpha-5 chains and alpha-6 chains. Today, we will speak about a disease with a defect affecting the alpha-1 chain. It is encoded by the COL4A1 gene, which is located on chromosome 13, A2A to COL4A2 genes, which are encoding the alpha-2 chains. So you have to know that these collagen IV molecules is widely expressed in all the basement membrane, including the muscles, the vessel, the eye, adipose tissue, peripheral nervous system, and also in the kidney. So what about its expression in the kidney? It is the first collagen IV molecules of the embryonic GBM, and you know that in adult GBM it is replaced by the alpha-3, alpha-4, and alpha-5 collagen IV molecules. But in the adult kidney, this molecule is highly expressed in the Bowman capsules basement membrane, in the tubular BM, also in the vascular BMs, and it is in the glomerulus, also present in the mesangium, and at low level it is expressed on the GBM, especially on the endothelial part of the GBM. So as a nephrologist, we all well-known collagen IV disease. Indeed, Alport syndrome is a collagen IV disease, and depending of the transmission, it is related to either COL4A3, COL4A4, and COL4A5 mutations. And the clinical symptoms in typical Alport syndrome associate hematuric nephropathy, deafness, and eye defect, which is due to the selective distribution of the COL4A3, L4, and A5 heterotrimers in the GBM, in the eye, and in the cochlea. The disease related to COL4A1 and COL4A2 gene mutations have been more recently recognized, first in 2005 by Gould and collaborators, who identified mutations of COL4A1 in families with autosomal dominant cerebral small vessel disease and eye defect. 2 years after, we characterized the Annack syndrome, which is a multisystemic presentation also associated with COL4A1 pathogenic variant. And more recently, some teams are characterizing non-syndromic form of COL4A1 disease characterized by selective eye defect. In 2013, mutation of COL4A2 have also been reported in families also presented cerebral small vessel disease with eye defect, phenotype very similar to the phenotype previously first characterized by Gould and collaborators. To date, there is no renal manifestation in patients with COL4A2 mutation. So the COL4A1 related diseases are autosomal dominant disease. Their frequency is yet unknown, probably rare, but also probably under diagnosis because of polysymptomatic forms. Indeed, there is a huge phenotypic variability within and between families with either single organ or multisystemic involvement, and in terms of age at the first manifestation and severity. And you can go from antenatal intracerebral bleeding, which is a very severe presentation, to clinically silent presentation through the life. But you usually keep in mind that it is mostly a systemic disease with a variable association of cerebral, eye defect, kidney disease, and muscle symptoms. And in case of when there is a diagnosis of COL4A1 related disease, the patient must have a systemic evaluation at diagnosis and during following, searching all potential organ defects related to this molecular defect. So I will first present extra-renal manifestation because they are most frequent, especially the cerebral manifestation and the ocular defect, and because most of the prognosis in this disease is driven by the brain involvement. So first, what about the cerebral manifestation? It is mainly a cerebral small vessel disease with clinical symptoms that can be of very different severity. Some patients with typical brain involvement by imaging may be asymptomatic. Some patients have only migraine or even epilepsy, which can be very complex. But typically, the typical presentation is the occurrence of stroke, mostly hemorrhagic stroke, which is very suggestive when it is observed in young people without classical risk factor for stroke. The brain imaging, especially magnetic resonance imaging, is very important to go to the diagnosis. And it shows features of small vessel disease with typically leukoencephalopathy with a typical periventricular pattern, as well as other abnormalities related to small vessel involvement with microbleeds, lacunar infarct, deep intracerebral hemorrhages, and also brain calcifications have been reported in patients with brain disease related to COL4A1 mutation. The most severe neurological presentation is observed in children who experience fetal brain hemorrhages that can be detected antenatally and which is responsible for severe cerebral malformation named porencephaly, which is a sequela of intracerebral bleeding, as well as schizencephaly, which are associated with the more severe clinical presentation with congenital hemiplegia, dystonia, and intellectual disability. Another cerebral manifestation, which is less frequent, observed in less than 10% of patients, is intracranial aneurysms. They may be unical or multiple, and they mostly involve the intracranial portion of the internal carotid artery, as illustrated here in this patient by arteriography with 3 aneurysms. You can see the large base, and to date, no episodes of rupture have been reported in patients with such lesion. The second frequent extra-renal manifestation is eye involvement. 3 distinct characteristics. First, congenital cataracts, which is the most frequent eye defect, but it can be also associated with more complex abnormalities of the anterior eye chamber, named Axenfeld-type-Rieger, and which associate variably iris abnormalities, microcornea, microphthalmia, and glaucoma. A third presentation is retinal arteriolar tortuosity, illustrated here in fluorescein angiography, and you can see the abnormal narrowing on the retinal artery, which is easily diagnosed by fundoscopic examination. These abnormalities are bilateral, and they can be totally asymptomatic may be associated with episodes of retinal hemorrhages, which are responsible for transient visual loss, but there is no long-term visual impact of these abnormalities. There are other external manifestations less frequently observed. The first is muscle cramps, which is selectively observed in patients with Anach syndrome. This muscle manifestation occur early in childhood. They are diffused and they may be increased by cold temperature. However, there is no associated muscle weakness, and the histological examination of skeletal muscle do not show any specific abnormalities. It is associated by elevated serum creatine kinase, but you may have such biological abnormalities without muscle clinical symptoms. And also electively in patients with Anach syndrome, you may observe the renal phenomena and supraventricular arrhythmia. What about the renal manifestation? The first renal phenotype you can observe is a multicystic kidney disease. It is illustrated here in this CT scan imaging from 3 patients. It is characterized by bilateral cysts, variable in number and size, and we have observed by successive imaging in time an increase of the size of the cyst, at least in size, but it is associated with a normal kidney size, and it is very distinct from classical ADPKD presentation. To date, no cystic complication have been recorded, especially no cystic hemorrhage or no cystic infection. And the impact on the renal function is variable. Here you have the CT scan of a patient, of a 57-year-old patient with a large cyst in the right kidney, and also several cysts in the left kidney, sorry. And you can see that there is nearly no impact on his renal function with an eGFR of 72 milliliters per minute. By contrast, in this man of 51 years old, you can see also multicystic kidney disease with various cysts. And at the time of imaging, the eGFR was impaired of 48 milliliters per minute. The patient showed a progression of his CKD, and 10 years later, he go to dialysis, and now is transplanted. And there is no other cause of CKD progression in this patient. This second patient was diagnosed at the age of 62, and at the diagnosis, you see that his kidney function was severely impaired with an eGFR of 32 milliliters per minute, and you can see the renal morphology with numerous cysts and a reduction of the thickness of the parenchyma. The second renal manifestation can be hematuria. Hematuria can be intermittent or permanent, and some patients report also growth episodes. It might be detected early in childhood, and it is an isolated hematuria without proteinuria of albuminuria, with normal blood pressure, and it is inconstantly associated with cysts. Here you can see the kidney biopsy of patients with Annac syndrome and microscopic hematuria. On light microscopy, the kidney looks normal, including the glomerulus, and except for the presence of red blood cells in tubular lumen. The distribution of the collagen IV alpha chains in the kidney was normal, and by electron microscopy, the glomerular basement membrane looks also normal, with normal thickness and structure. However, when we carefully analyze the Bowman's capsule basement membrane and the tubular basement membrane, we observe huge abnormalities, with BM being thickening and having a multilaminated aspect, as observed in the GBM of Alport syndrome. What about the potential progression of CKD in this patient? To date, only few cases of CKD progression have been identified, and I will briefly comment these two pedigree. The progression of CKD is usually associated with a multicystic kidney phenotype, and it is inconstantly associated with a proteinuria occurrence, and who occur only if eGFR is below 50. And in all patients who reach end-stage renal disease, the age of dialysis was 50 years. So this first pedigree was published by Denigel 3 years ago. In this pedigree, a mutation of COL4A1 in the INC1 domain was co-segregated with hematuria in all affected patients, and some patients also, most of the patients have a cystic kidney disease, as previously described. And you can see that in the older patient, most of the patients developed severe CKD, and some of them reach end-stage renal disease, while the younger patients have a preserved eGFR, despite a cystic phenotype, meaning that you must follow the patient long life to detect progression of the disease. Here, an ANAC family, also with a cystic and hematuric phenotype. You can appreciate that some patients with hematuria do not show a cystic phenotype, but the older patient show a CKD progression, with this patient going to end-stage renal disease at 75 years old. This patient I previously presented go to end-stage renal disease at 62 years, and this patient has a renal impairment at 65 years, but died by brain hemorrhages. Other renal manifestations have been recorded, but exceptionally, and we can ask for incidental findings, especially unilateral renal agenesis and hydronephrosis. So there are distinct presentations of COL4A1-related disease. They may be syndromic or non-syndromic. The most frequent clinical presentation associate cerebral small vessel disease with usually severe neurological presentation. The more severe is, of course, antenatal cerebral hemorrhages with development of porencephalic, but also later in life by unique or recurrent stroke before 50 years of age, and also complex epilepsy. And it is variably associated with ocular defect, but you can also have non-progressive hematuria, CKD elevation without muscle signs, and cerebral aneurysms. The second syndromic presentation is ANAC syndrome. ANAC is for hereditary angiopathy, nephropathy, aneurysms, and cramps. It typically associates retinal arteriolar tortuosity, muscle cramps, multicystic kidney disease with or hematuria that may progress to CKD and stage renal disease. Usually in ANAC, the vascular brain disease is polysymptomatic, and some extra systemic microvascular manifestations are present with renal phenomena and supraventricular arrhythmia. Non-syndromic form of congenital cataracts, microphthalmia, retinal arteriolar tortuosity, or cerebral small vessel disease have been also described. What about the genetic characteristic? Here you can see a schematic representation of the alpha-1 chain of collagen IV with a large collagenous domain, which is characterized by the repeat of the glycine XY triplet of amino acids, which is characteristic for collagenous molecule. The glycine is very important for the formation of the triple helix in the heterotrimer. There is a small N-terminal 7-ACE domain and N-terminal non-collagenous domain, which is very important for the trimerization of the molecules. It is encoded by alargins with 52 exons. So to date, about 90 COL4A1 pathogenic variants have been reported, exceptionally frame shift mutation, splice site mutations, but the majority of mutation are missense mutation with mostly glycine, which are responsible for glycine substitution in the collagenous domain. When we looked at the distribution of the glycine substitution, most of them, more than 80% of the glycine substitution, are located after exon 26 to exon 48 in the collagenous domain, and exceptionally between exon 10 and exon 24. Interestingly, patients with typical ANAC phenotype are mutations that are located in exon 24 and exon 25, missense mutation, leading to glycine substitution in a small part of the collagenous domain of 20 amino acid lengths. And interestingly, this domain contains a binding site for integrins. It is the only genotype-phenotype correlation, while there is no correlation with extra-renal manifestation or the severity of the manifestation whenever the mutations are located. Some mutations are located in the NC1 domain of the protein and few in the 7A domain. Today, there is, except for ANAC, the phenotype variability is not explained by the location of the mutation, and as usual, we can ask for the role of modifier genes or environmental factors to explain such phenotypic variability. So, what about the diagnostic approach for the nephrologist? Indeed, you can ask for COL4A1 disease in case of familial hematuria or multicystic kidney disease. So first, you have to search for suggestive extra-renal manifestation in the patient, but also in the family, especially the occurrence of neurological event before 50 years, the presence of muscle cramps, migraine, episodes of transient visual loss, and of course, familial complex. You have to perform a neurological examination and also brain magnetic resonance imaging that may detect silent brain involvement. Fundoscopic examination is a very easy way to diagnose retinal arteriolar tortuosity, and elevation of serum creatinine may be suggestive. So, in case of suggestive extra-renal manifestation, moreover in a familial context, or if the patient was negative for gene abnormalities for ADP-KD in port, you can ask for a COL4A1 gene screening. Today, it has been included in ENGS panel of polycystic kidney disease, and also it must be included in panel for hematuric syndrome. What about the differential diagnosis? Indeed, for the neurologist, it is the field of inherited cerebral small vascular disease. And for ophthalmologists, the field of inherited anterior diagnoses. But in all this genetic disease, there is no associated renal defect. And for the nephrologist, of course, the differential diagnoses are other forms of autosomal dominant polycystic kidney disease and hematuric nephropathy, and mainly Alport syndrome. What about the management of this patient with established COL4A1-related disease? Today, there is not a specific treatment. Once again, you have to investigate the extent of the disease at diagnosis and at follow-up according to organ defects. There is, of course, symptomatic therapy for epilepsy, for eye abnormalities. And one thing that is very important is to prevent the risk of stroke. And in this patient, you have to avoid anticoagulant therapy and aspirin, if possible, to treat hypertension if needed, to ask for smoking cessation, and generally to avoid situations with an increased risk of head trauma. There is also a concern for pregnancy because the problem is to potentially prevent brain injury due to birth trauma in newborns. So the pregnancy should be tightly followed and with fetal brain imaging, and cesarean can be discussed to prevent birth trauma and the occurrence of neonatal brain bleeding. Last, of course, the patient should have a genetic counseling as well as his relatives, and you have to discuss prenatal testing, even pre-implantation genetic diagnosis in case of history of antenatal brain hemorrhage. So, in conclusion, COL4A1-related disease are multicystic disease with a very important phenotypic variability. The prognosis is mostly linked to the cerebral complication, so you have to prevent, to have an action for the primary prevention of brain hemorrhages, and to discuss prenatal testing and pre-implantation genetic diagnosis, particularly if there is a history of fetal brain hemorrhages. Regarding the renal involvement, the most frequent is a multicystic kidney disease. So it can be detected by sequencing, and now most of the panel for ADPKD include COL4A1 analysis. And it is not usually a benign disease, and you have to follow up the patient in long term, because the renal function remain normal before since 50 years old, but can be progress rapidly afterwards. It is also a cause of autosomal dominant familial hematuria. So in this case, you have to search for suggestive extra-renal manifestations that are distinct to Alport syndrome. And of course, I think that now COL4A1 should be included in NGS panel for hematuric nephropathy. So I am finished. Before going to the question, just an announcement for the next webinar in March 21, which will be given by the whole survey of APOL1 risk genotype in FSGS and other nephropathies. And I thank you very much for your attention, and I will be happy to answer to all your questions.
Well, thank you very much, Emmanuelle. This was a wonderful lecture, and I think we learned a lot. Do you have multiple choice questions now?
Yeah.
Yes. Maybe we can run them so that we can see how well people have followed you.
Yeah. So the first question was, which extra-renal manifestations are observed in COL4A1-related disease? Stroke, deafness, cataract, migraine, arrhythmia? Okay, so the answer is stroke, yes. Deafness, not. So it's a very important negative sign for the differential diagnosis with Alport syndrome. Cataract, yes. Migraine, yes, and it can be the only neurological manifestation. And arrhythmia, cardiac arrhythmia also, it is supraventricular arrhythmia, mostly reported in ANAC patients. So the second question is, which renal manifestations can be observed in COL4A1-related disease? Gross hematuria, nephrolithiasis, hypertension, end-stage renal disease, and multicystic kidney disease.
Non sono particolarmente ipertesi.
So, gross hematuria, yes, of course, it's rare, but some patients report episodes of macroscopic hematuria. Nephrolithiasis not. Hypertension is very uncommon unless end-stage renal disease, so it is not a suggestive sign of renal involvement in COL4A1-related disease. End-stage renal disease, yes, it rarely occurred, but it may occur, so the patient must be followed through the life by a nephrologist. And multicystic kidney disease, of course, it is the more frequent renal manifestation, especially in ANAC phenotype. So ANAC syndrome typically associates cataract, retinal arteriolar tortuosity, porencephaly, cerebral aneurysms, and muscle cramps.
Tutti.
So ANAC syndrome, I remind you, it is an acronym for hereditary angiopathy, nephropathy, aneurysms, and cramps. And cataract is not typically observed in ANAC. It can be observed as other phenotypic presentation of COL4A1, but it is not a strong sign of ANAC. By contrast, retinal arteriolar tortuosity are constantly observed in ANAC and is very suggestive in the presence of multicystic kidney disease and muscle cramps. Porencephaly, we never observed porencephaly in ANAC. In ANAC, the brain disease is usually polysymptomatic, and porencephaly, by contrast, represents a severe brain involvement, being a sequela of antenatal brain bleeding. Cerebral aneurysms are very frequently observed in ANAC patients, and of course, muscle cramps are constantly observed in ANAC patients. So the last question regarding the genetic characteristic commonly observed in COL4A1-related disease: autosomal recessive transmission, autosomal dominant transmission, missense mutations, large rearrangement, and glycine substitution. So, COL4A1-related disease transmitted as an autosomal dominant trait and not recessive. Recessive is expected, transmission will be expected to be lethal because COL4A1 is very important early in embryogenesis. So we don't expect to see patients with autosomal recessive form. So it is really an autosomal dominant disease. The most frequent gene mutation characterized in COL4A1 are missense mutations. To my knowledge, large rearrangements of COL4A1 genes have not been reported, but some genetic lab are search for systematically for such defect. And among the missense mutation, glycine substitution represents the typical abnormalities, especially and mostly in the collagenous domain of the protein.
Okay, very well. Thank you, Emmanuelle. Please send in your questions and I will read them for you. So far, I have no questions, but I have a big applause from Albertine Van Erde that is sending you her congratulations. So let me ask you a few questions, if you don't mind.
Yeah.
Do you know what is the cause for the muscle cramps?
Yes, we have a preclinical model in mice with ANAC mutation. And what we observed is not a primary defect of the skeletal fiber, but a primary microvascular defect, which probably impact the skeletal muscle function by ischemia. And we can see by light microscopy on the mouse muscles focal hemorrhages and abnormalities that may be a consequence of chronic ischemia with fibrosis. And interestingly, how can we explain a primary defect of the microvessels of muscles is that the basement membrane in a muscle is not synthesized by the muscular fibers, but by fibroblasts and endothelial cells. So it's probably the consequence of endothelial dysfunction and ischemia more than a primary defect of the muscular fiber. And so, it is very interesting to, sorry, Francesco, patient clearly say that in winter or when they are to the swimming pool with a cold water, the muscle cramps increased. That may be a manifestation of vasoconstriction and muscle ischemia.
Oh, okay, and so so the cramps are typically bilateral; they're not unilateral, right?
Yes, bilateral, and they can affect any muscular groups, including in the face, but very diffuse and not typically on the leg or on the arm. Very any muscular groups. Yeah.
Okay, then I was wondering whether you have any notion about what is the frequency of de novo mutations?
It's very, to date, it's very difficult to answer. There are de novo mutations are mostly identified in children with antenatal brain hemorrhages. But it is yet, there are de novo mutations have been reported, of course, but it is very difficult. I think among the 90 mutations, it may represent about 15 to 20%.
So in practical terms, if you don't have a family history, you can still have ANAC with a de novo mutation.
Yeah.
That was my point. So Aberdeen Van Erde is asking you the following question. You show that specific exonic 24 to 26 location for ANAC, and she missed outside these locations. There are no mutation in ANAC patients, or in this location, no other COL4A1 phenotypes are described, or more, or is it more complex?
There is inside the 24 and 25 exons, there is one patient who share one family, it is a Spanish family, who shares the mutation with one ANAC family without the complete typical ANAC phenotype. And outside, of course, you can have retinal arteriolar tortuosity with a brain phenotype or hematuria or cyst outside the ANAC location. But really, ANAC is there is the free manifestation with cramps, retinal arteriolar tortuosity, and renal involvement is very it never missed. So of course there is a broad phenotype with but ANAC is patient with ANAC are really no patient all patients with ANAC and mutation in this location have constantly have retinal arteriolar tortuosity, symptomatic muscular cramps, and renal disease. But of course, there is outside this location, you can have some manifestation in bracket of ANAC, but it's not a typical ANAC.
Okay, that was very clear. So Christy Thomas is asking, what is the pathogenesis of cysts? Is it due to tubular dilatation or to tissue damage?
Yeah. So once again, on the preclinical model, in the mouse model with ANAC mutations, the cyst, they develop renal cyst and glomerular cyst. It is not tubular cyst. And so, of course, in patients, it is very difficult to confirm the glomerular origin of the cyst because we have kidney biopsy of a patient early in the course of the disease and not in a patient with age over 50 years. But so probably you see the huge alteration of the basement membrane, of the Bowman capsules. And one hypothesis is to the intraglomerular accretion may promote urine chamber dilatation and the occurrence of cyst. There is, however, no tubular cyst, despite also the abnormality of the tubular basement membrane. So it is probably a glomerular cystic kidney disease, but we have no proof yet in human. But in mice, it is a glomerular cystic kidney disease.
That's very interesting. Just a small question from Dr. Menka Yadav regarding kidney donation. I'm reading you the question. He has a question regarding voluntary kidney donation status from asymptomatic mothers, also for those with previously unreported variations.
Yes, obviously from relatives with mutation, we cannot recommend, not even if there is no kidney involvement in the donor, but you know there is a multisystemic kidney. It is a multisystemic disease, and especially there was a brain susceptibility, a vascular brain susceptibility, and I think that we cannot take the risk of surgery in such patient. Even if it's low, I think it's not recommended. For relatives without the mutation, I think there is no problem for kidney donation. And in the patient I described who were recently transplanted, it is ANAC phenotype, and it was a donation for his brother without COL4A1 mutation.
Well, okay, then I have another question, which is a more broad question. Is there any relationship between COL4A1 mutation Alport syndrome? And the same question, is a renal biopsy needed for diagnosis?
So I think that regarding, there is hematuric nephropathy. The difference are extra-renal manifestation first. Second, regarding for the diagnostic impact of the kidney biopsy, of course, in COL4A1 disease, there is no glomerular basement membrane abnormalities. And in typical Alport syndrome, there are GBM abnormalities, but you know that some patients will COL4A3, 4, or 5 mutations, especially those with autosomal, with heterozygous mutation, may have an early normal GBM. So I think really the genetic analysis of the collagen IV genes involved in so COL4A1 and COL4A3, 4, 5 are required if there is no other typical extra-renal signs in favor of COL4A1-related disease or Alport syndrome.
Yeah.
And to date, we don't understand where come from the red blood cells in urine, you know, because the GBM is normal. So is it of tubular origin? I don't think so. And once again, in mice, they have hematuria, and we see red blood cells in the urine chamber, meaning that the hematuria probably comes from the glomerular alteration. But yet, we don't know really what is the pathogenesis of the hematuria.
Okay, thank you very much, Emmanuelle. These last two questions were from Dr. Elamine. So I think we've come to the end of the questions and then to the end of the seminar, which was really very interesting. Thank you everybody for listening. And again, thank you, Professor Plaisier, for this wonderful lecture. And until next time, we are looking forward for all cell-based seminars. Thank you very much.
Thank you very much, Francisco, and thank you all for your attention.
Bye.
Bye.